And we now move to Professor Dag Aarsland, who's a colleague of mine at the Institute of Psychiatry, Psychology and Neuroscience. And Dag is going to be lecturing us about unveiling the enigmatic relationship between depression and neurodegeneration. And we'll have time for a few questions at the end. So over to Professor Aarsland. Thank you very much.
I want to thank the organizers for inviting me to this distinguished meeting and for the opportunity to talk about dementia and depression. So the title of the talk is Unraveling the Enigmatic Relationship Between Depression and Neurodegeneration. So the focus of my presentation will be to address these three questions. Is depression associated with the risk of Alzheimer's disease and Parkinson's disease? Secondly, if so, what are the possible mechanisms for such an association? And third, can we prevent dementia and possibly Parkinson's disease by treating depression in late life? So depression is common across all ages, but it's increasingly common with age. And this is a large study, a Norwegian population-based study showing that the frequency of depressive symptoms is increasing with age, both in men and women. And this has been shown in a range of other studies, although the frequency of people with major depression might not increase with age. Another very common and relevant age-related health problem is dementia. As the world population is aging, the number of people with dementia is increasing from 50 million today, the next decades up to 130 million people. So this increase will happen all over the globe, not only in the Western world, but also in Asia, with a large number of people with dementia expected in China and India. And as you can see upper right, with the staggering costs for the societies. So both depression and dementia are among the most important health issues for older people, and the number of older people is increasing. So these are then already very important challenges, which are expected to increase dramatically during the next decades. So there are a number of issues connecting depression and dementia. One is that there are a number of overlapping symptoms. We can here see the list of depression symptoms, and those in red are also very commonly seen in people with dementia, including obviously concentration impairment, fatigue, decreasing energy, sleep problems, irritability, restlessness, loss of interest, and appetite disturbances. So we have one challenge being differentiating between depression or dementia, which is one clinical challenge. Today, I'm going to talk more about another important aspect linking cognition and mood or depression. As we can see here, and as you will know, impaired cognition is a very common part of the syndrome of depression. And while we can see that the typical scenario of mood, so acute phase, remission, then often, but not always, a relapse and a new episode, etc. Cognition is usually impaired in depression, but the course of cognition may vary. We can have a remission, as with the mood symptoms, but the cognition can also remain impaired and can even, in addition, can even worsen despite remission of the mood symptoms. And these issues with cognition, they are particularly relevant in depression in older people. So we have then a very complex relationship between depression and cognition. So as we've heard, cognitive impairment, typically dysexecutive syndrome, is typical in depression. But we also know that people with depression in midlife have an increased risk of dementia later on. And we also know that people with dementia have an increased risk of depressive symptoms. We have a bidirectional relationship between dementia and depression. So what are the possible mechanisms of depression leading to dementia? So on the one hand, depression can be seen as a risk factor for later dementia. But also in older age, late onset depression can be seen as a prodrome of dementia, as well as Parkinson's disease. We can have common risk factors, pathologies, which are leading to both depression and dementia. And finally, depression can be seen as a reaction to emerging cognitive decline. And obviously, these four possible mechanisms of association are not mutually exclusive. We can have a combination of them. So what do we know about the risk of dementia in people who have had depression? This is a meta-analysis performed by the World Alzheimer's Report, published several years ago. And since then, new studies have emerged. But here they compiled 32 studies with more than 60,000 participants, and as you can see, a double risk of developing dementia in those who have had depression earlier in life compared to not having had depression. So depression is a clear and one of the most important aspects or risk factors, even potentially modifiable risk factors of dementia. Another study of 16,000 participants from Korea looked into more details of the depression and found that it was particularly those with persistent depression that had an increased risk of dementia, whereas childhood but also late onset depression in this study was not associated with dementia, but persistent depression indicating that severity of depression, but also maybe treatment resistance might represent a risk for later onset of dementia. This is a study by our group from PC student Maria Bokarova looking into details of the Protect Online cohort in the UK, where we have more than 15,000 people who have provided data on depression, anxiety, and cognition over time. It's completely online study. People are included aged 50 and above without dementia. And we can see here that people who have had depressive symptoms had a worse performance over time on one of the cognitive tests, the SPAN test. But you can also see that people who have anxiety had a worse performance over time on spatial working memory tests. So again, showing that depression is associated with worsening cognition. So then, in this important paper from the Lancet Dementia Commission Group, published last year, focusing on the modifiable risk factors for dementia. This paper also discussed whether these risk factors represent the potential for prevention of dementia. And as you can see, there were two main strategies for how a risk factor modification could influence dementia. One is by reducing the neuropathological changes related to dementia, mainly Alzheimer's disease. And on the other hand, factors which could increase the cognitive reserve. And as you can see, among the many relevant risk factors relevant for potential prevention of dementia, depression is one factor, and thus reducing the occurrence of depression is one key factor. Both potentially reduce neuropathology of Alzheimer's disease and other dementias, but also lead to increased brain reserve, increased cognitive reserve to prevent or delay the onset of dementia. Other researchers have looked into whether or the potential magnitude of dementia reduction, looking into if the different risk factors could be reduced or even prevented totally. And we can see for depression that the estimated potentially attributable risk number of people with dementia related to depression worldwide is 2.6 million. And we can see in the graph estimated numbers of reduction of dementia compared if the risk factors were reduced by 10 and 20% respectively. You can also see below the numbers for UK and with the increased up to 2 million people with dementia can be quite dramatically reduced if it would be possible to prevent the effect of depression on dementia. These are models, but represent a potential scenario, and it also demonstrates the potential magnitude of effect of dementia by treating depression. As we will discuss later, we don't yet know that it is possible to reduce dementia by improving or reducing depression, but it is very likely to be true. In addition to Alzheimer's disease and dementia, depression has also been shown to be a prodromal of Parkinson's disease, as shown in this work by Daniela Berg and Postuma. So also in Parkinson's disease, another neurodegenerative disease, the second most common neurodegenerative disease after Alzheimer's disease, there are a number of risk markers, and there are also prodromal markers, and depression is a very established prodromal of Parkinson's disease. So people who have depression, usually in later life, can go on to develop Parkinson's disease. The authors could also have chosen to include depression in the list of risks for Parkinson's disease, because it is also known, fairly well established, that people who have had depression early in life have an increased risk of Parkinson's disease later in life. And this is another study exploring the association between depression and Parkinson's disease. And if you see on the right hand, particularly this effect is clear in the older group with the risk of Parkinson's disease in the years following the depressive episode. And you can also see that this was particularly related to the number of adequate treatment episodes. So if you have a number of non-responding treatment episodes, the risk of developing Parkinson's disease is particularly high in older patients. And another way of looking into this association between depression and Parkinson's disease was performed by this group from the UCL, led by Annette Schrag, where they studied a group of late onset depression and looked into clinical and imaging markers of Parkinson's disease. And they found that compared to healthy controls, older people with onset of depression had more clinical signs of Parkinsonism compared to the controls. And also, interestingly, looking at dopamine transporter SPECT, a marker of nigrostriatal degeneration, which is a diagnostic marker of Parkinson's disease, indicating loss of nigrostriatal neurons. In the late onset depression group, the proportion of people with abnormal dopamine transporter scan was 24-25%, much higher than in the control group, indicating subtle Parkinsonian changes already in this group, suggesting that they will go on and to develop manifest Parkinson's disease. So then what are the mechanisms of depression in late life? So this slide shows a number of them. Firstly, there are a number of them, obviously psychological and social factors, but also brain-related factors, and vascular changes, inflammation, neurodegeneration, and altered neurogenesis are factors which are likely to contribute to depression in late life. And interestingly, these are also factors which we know are factors contributing to dementia, so could be a common pathological factor leading to both depression and dementia, thus explaining this association mentioned earlier. So let's look into this in more detail. This slide shows one of several studies showing an association between cerebrovascular disease, white matter lesions in older people, associated with an increased risk of developing depression later on. So those who have more white matter lesions in the brain go on to develop depression. And obviously they also go on to develop cognitive impairment and have a higher risk of dementia, vascular dementia or mixed vascular and neurodegenerative dementia. So this has then led to the concept of vascular depression, which has gained a lot of traction and is well established. So another mechanism combining a combined mechanism for both depression and dementia is inflammation. You can see here neuronal stress leading to microglial activation, leading to both neurodegenerative changes and a release of pro-inflammatory cytokines and reduction of anti-inflammatory cytokines, which then leads to neuroinflammation and leads to damage of synapses, damage of neurons, and in the end, neuronal loss. So these changes can then lead to both depression and can lead to dementia, Alzheimer's disease, neurodegeneration, and obviously the combination of the two. This was also shown again by Maria Bukarova, looking into people with late onset depression. And as you can see, compared to controls, a number of pro-inflammatory cytokines were increased in plasma of people who had late onset depression compared to healthy controls, indicating the association between depression and inflammation. And several studies have been performed by many groups of different populations. A third mechanism potentially linking depression and neurodegeneration is altered hippocampal neurogenesis. So as you will know, in the hippocampus and other areas of the brain, there are niches which contain endogenous neuronal stem cells, which can proliferate, migrate, and mature into well-functioning neurons with synaptic connections, which have been shown to have functional relevance. This neurogenesis, this proliferation, maturation of neuronal stem cells can be influenced by a number of factors. So we know that chronic stress leading to increased cortisol, the HPA axis, etc., is a factor which reduces the neurogenesis in the hippocampus. We also know that aging has the same effect and poor diet has the same effect. On the other hand, positive factors stimulating neurogenesis and the maturation of neurons include SSRIs and exercise and a healthy diet. So neurogenesis is both a factor that can contribute to or reduce neurogenesis, can contribute to depression, dementia, maybe the link, but it is also an opportunity to to reduce the risk, to protect the brain, to increase neural activity. I just want also briefly to mention that exercise, as I mentioned, is one of the well-known factors stimulating neurogenesis. Is an important way of manipulating this system in a positive way, and as you will know, it is known to be a treatment of mood disorders, and it's also probably one of the strongest protective factors against development of dementia. So physical exercise is good. It's good for the brain, both by increasing neurogenesis, but also by a number of other factors, including muscle release of neuroprotective substances from the muscles itself. So then let's move on over to the last and the fourth potential mechanism linking depression and dementia, which is neurodegeneration. There are a number of studies have looked at whether depression is associated with neurodegenerative aspects, mainly focusing on Alzheimer type pathology, amyloid pathology, and also tau pathology. So we show a couple of studies from my time at Karolinska, and they have a large memory clinic seeing a number of patients, and they all worked up with a system of biomarkers, including cerebrospinal fluid collection, which we can see here. And we can see that we have here people with Alzheimer's disease and without Alzheimer's disease, and the Alzheimer groups have reduced concentration of A-beta-42 as expected. You can see in both groups, we have split the patients in those who had or did not have depressive symptoms on a depression scale. So these are not clinically depressed patients, but they are memory clinic patients with depressive symptoms. And we can see here there were no association between having depression or not in the two groups. So depression did not seem to be associated with amyloid pathology in this cohort. Similarly, when we looked into another marker of Alzheimer's disease, medial temporal lobe atrophy, MTA, on hippocampus, which you can see on the right, and the red arrow showing medial temporal lobe atrophy compared to a normal medial temporal lobe on the left, and the blue arrow. We can see again that atrophy was more pronounced in the Alzheimer group compared to the non-Alzheimer group. But you can also see that there were no clear difference between those who had depression or not, either in the Alzheimer group or in the non-Alzheimer group. So depression was in this group not associated with atrophy of the medial temporal lobe of the hippocampus. And similarly, another study by Dag Aarsland from a cohort in Oslo, we can see here that not only was there no association or no increased pathology in depressed, but actually the other way around. The more severe the depressive symptoms in these patients who had MCI, the more normal was the cerebrospinal fluid in terms of Alzheimer type markers. So those patients with MCI who had the lowest level of depression had the most marked Alzheimer type pathology in the CSF. So suggesting that in people with depression with the same level of cognitive impairment, there are factors other than amyloid pathology that contribute. However, when we look into another cohort, which are patients who have clinically significant depression, so this is a cohort also from Oslo, where we had the opportunity to look into the CSF of people who had clinical depression. They were admitted to psychiatric all-day psychiatry ward for depression, and we found two things. One is that in approximately half of them, there was a reduction of CSF A-beta-42 Alzheimer type markers. So half of late onset depression, there were Alzheimer type changes, which might indicate an early Alzheimer's disease, or might have another link between Alzheimer or amyloid pathology and depression. And secondly, we also looked into synaptic markers, and you could see that the synaptic markers here, postsynaptic neurogranin and base 1, those levels were distinct in late life depression with and without Alzheimer's pathology. So those who had abnormal CSF A-beta-42 had increased levels of neurogranin, whereas those who had normal levels of CSF and depression had normal levels of synaptic protease, indicating an association between synaptic pathology in depression, which is related to the Alzheimer's type pathology. So there are several ways of exploring Alzheimer's type or amyloid pathology. In addition to cerebrospinal fluid, it's also possible to do a molecular PET imaging and with a variety of ligands binding directly to the amyloid plaque. And this is a study showing that in elderly depressed patients who had amyloid pathology based on molecular imaging, there were a number of structural and functional changes in the brain, indicating that this Alzheimer's type pathology has clear functional consequences in the brain and then also likely on the clinical course of these patients. So then we are touching into the final topic, which is about treatment implications. So again, following up on the study on pathological amyloid levels in the brain using amyloid PET, this study demonstrated that those people, older depressed patients who had an abnormal scan, amyloid pathology in the brain, they had a poorer response to antidepressant treatment. So the Alzheimer's type pathology had a clinical impact in terms of making it more difficult to reduce the depressive symptoms in standard antidepressant therapy. So clearly these assessments have clinical relevance. And another interesting study indicating a potential for prevention of dementia by treating depression in old age. This is a study based on the ADNI cohort, people with early stage Alzheimer's disease followed longitudinally. And here they looked into the association between having depression and developing dementia, progression from no dementia to dementia over time. And at first, you can see at the upper left, there were no clear association between depression and development of dementia. However, in the upper right quadrant, you can see that when we look into different treatment modalities, those who had a long-term SSRI treatment had a reduced risk of developing dementia after adjustment for a number of factors. And that as you can see below on the table, that difference was statistically significant, both in terms of the total risk for dementia, but also in the time to develop dementia. There was a positive effect of a long-term treatment of SSRI, indicating the potential of preventing dementia by treating with SSRIs. Then nearing the end, but just wanted to say that the various antidepressants might have differential effect on the potential risk for dementia. And this is two interesting studies with the drug vortioxetine, as you are familiar with, I guess, having a number of interesting pharmacodynamic properties. In addition to being an SSRI, it's also acting on a number of relevant serotonergic and other neurotransmitter receptors. And this first study back in 2012 by Cornelius Cartona, showing that vortioxetine had an antidepressant effect compared to placebo, similar to duloxetine. Vortioxetine was more effective on improving cognition on 3 different cognitive tests compared to duloxetine. So showing an indication of, in addition to having an antidepressant effect, better, stronger pro-cognitive effect compared to other antidepressants. And to the right, you can see an interesting study in rats showing that vortioxetine, compared to fluoxetine, has a stronger positive effect on neurogenesis. See a number of measures indicating a stronger neurogenesis. You can also see in the middle of the page a graph showing that there was an association between the level of neurogenesis and behavioral tests. And then the big quadrant, you can see a schematic diagram of the neurons that develop during treatment with vehicle or fluoxetine or vortioxetine. You can see the longest dendrites and the most branching of dendrites are seen in the vortioxetine group, indicating a particularly strong neurotrophic or effect on neurogenesis by vortioxetine compared to other drugs. So that I want to summarize and conclude. So we have seen that depression is a risk factor for Alzheimer's disease and Parkinson's disease. That depression is also a prodromal for Alzheimer's disease and Parkinson's disease. That the mechanisms for these associations are probably heterogeneous. Key factors are cerebrovascular disease, neurogenesis, and inflammation being very likely candidates, and maybe also in combination. Regarding the effect of Alzheimer-type amyloid and other pathologies and depression, there are more mixed findings. Some studies support an association, others not, and probably, again, there's a heterogeneity here. In some patients with depression in old age, Alzheimer pathology seem to play a role. And this association between depression and a later risk for dementia opens a window for prevention of dementia. And clearly that is a key future area for research. And there are some preliminary evidence indicating that antidepressants may reduce the risk for developing dementia, in particular in treatment of depression in older people. So I want to thank particularly my PhD students, Maria Bakarova, Thomas Berger, Niklas Siafarakis, and Eirik Auning. And thank you for your attention, and I'm happy to take questions. Thank you.
Well, thank you very much, Dag, Professor Aarsland, and that was a fascinating talk about depression and neurodegeneration. We've got about 6 or 7 minutes for questions. First question that's come through, Dag, is about the effects of COVID on depression and dementia in older people, and there's a related question about social isolation. So I guess if COVID was going to affect depression and dementia, one of the ways in which it might affect it is by social isolation. I wonder if you could comment on that.
Okay, thanks. Obviously a relevant question. And as Alan says, yes, social isolation is one factor driving both depression and anxiety. And as you will know, older people have been particularly recommended to shield and to isolate during all these months. And we have seen studies by us and others that there is actually an increase in symptoms of anxiety and depression in this group, as in many other groups, obviously. But we also know that these people are, let's say, less resistant, both from a physical and a mental health standpoint. And obviously the risk for more severe consequences of these symptoms are clearly relevant. Obviously, that's not something we have looked at in detail yet, but it's obviously clearly something to look into. But on the other hand, and in addition, obviously, we have the effect of the infection itself on the brain, and that's also a huge and very important future topic. So clearly, the pandemic has made this relationship even more relevant and important.
Yeah, I mean, I guess the other thing to say is that much of the research that you and your colleagues do is in networks which go into care homes, and of course they've been dramatically affected by the pandemic. Apart from anything else, there's been a very regrettable increase in death rates. Any comment on the situation in the care homes?
Yes, that's also relevant, clearly, and obviously in these places, many people already have dementia, so that's a different challenge. But we have seen that people with dementia in care homes during the pandemic have had an increase in behavioral challenges or disturbed behaviors, agitation, psychosis, depression, apathy, and that kind of things related to many things. Obviously, the lack of contact with loved ones and family members. And we have also seen an increase in the use of antipsychotics in this group, which is also very worrying, and it's clearly something that needs to be focused on. We have several studies in the pipeline now, and we're trying to get into care homes, but obviously they have a lot of things to worry about beyond being enrolled in trials on this, but clearly a very important area.
Yes, of course. And I think you've got some very innovative trials underway looking at things like cannabinoids for behavioral symptoms of...
Exactly.
Yeah. Okay, a few more questions. Is depressive pseudo-dementia still a valid concept?
That's a good one. So, well, yes, in the sense that, as we've heard, cognition is impaired in depression, but no, in the sense that any cognitive impairment is pseudo-dementia, because as you have now seen, some depressed older people with cognitive impairment go on to develop dementia. So just to make the confusion even higher, the term pseudo-dementia has been coined, so meaning that something that looks like pseudo-dementia is actually real dementia. So, but I guess probably instead of having terms like pseudo-dementia, we just say dementia is a factor to consider in older people with depression.
Yeah, quite. Do antidepressants have a role in preventing dementia in people who aren't depressed?
Yeah, well, very clever question, and obviously we don't know, but it is possible, as we have seen a number of effects that might relate to this, but I guess the first question is to see, does antidepressant in people with depression reduce the risk for dementia, which is in itself would be a major benefit and very important study area. If so, that could then potentially be moved to non-depressed population, but obviously that's somewhat more controversial and a different question. But I agree, it's a relevant point.
I mean, there is some data showing that lithium, for example, and lithium, of course, is a GSK3 beta inhibitor, so there's a relevant pharmacological mechanism. Lithium may reduce the rates of dementia, so it's an interesting topic for the future. Further question is depression one thing, or is it multiple disorders? I mean, before Professor Aarsland answers, my own view is that depression is the psychiatric equivalent of fever, and it may be due to, it's a symptomatic manifestation of multiple underlying causes, but I certainly think that the elderly onset depression is a distinct subtype. But Dag, over to you.
Yes, thank you, and I would obviously not argue with you there, Alan, and I think probably in the older depressed population, I think the heterogeneity is even larger than in the general population, because of the added factors that we have discussed in the talk, like cerebrovascular disease, physical disease, etc., etc. So in this group, there's a plethora of different mechanisms leading to depression. Whether you want to call them subtypes or not, that's another issue. But clearly, I think the findings that although antidepressants clearly have a role and are efficient in older people, they seem to be on average less effective than in the general adult population, and that is probably related to that there are subgroups within older depressed people who have depression which is less responsive to antidepressants, for example, because of cerebrovascular pathology which contributes to depression, and then is probably less likely to respond to antidepressants.
Yes, I think that's true. But the vortioxetine data is really quite good. I mean, I guess one thing that I would say is that we should have separate trials of antidepressants and related treatments in the elderly population. I think just extrapolating from a group whose mean age is 40 to people aged over 60 or 65 is probably not acceptable anymore. Would you agree, Dag?
Absolutely, absolutely. So these studies will then usually have like 10% or so older people, and it's impossible to extract from them. So we need specific trials, and there are some of them, but we need more, and also focusing more on cognition, I think.
Yes, of course. Professor Aarsland and I are working on a definition of what constitutes being elderly, but at the moment our working definition is at least 5 years older than us. But of course that may well be a biological. Let's squeeze in a couple more questions. Is it worth treating depression in Parkinson's disease? Do people respond? Does the depression respond to treatment?
Absolutely, yes. So there's good evidence also for meta-analysis that antidepressants can improve depression in Parkinson's disease. And again, there are various drugs that have shown efficacy, including venlafaxine. And also interesting, there are studies looking into dopamine agonists showing that at least in people with mild depression and Parkinson's disease, dopamine agonists, including pramipexole, seem to improve depressive symptoms in Parkinson. And I can also end by saying that electroconvulsive therapy, ECT, is an interesting option in Parkinson's because in opposite what you might think, is also beneficial for the motor symptoms because of the dopamine, increased dopamine activity related to ECT. So never give up on a depressed person with Parkinson's disease.
Okay, just let's squeeze in two more, and then I'll let you get back to gazing at your fjords in lovely Norway. Is it worthwhile treating someone with MCI and subclinical depression with an SSRI or vortioxetine?
The short answer is yes, and the argument would be that these terms of depression do not particularly well relate to the depression scenario in older people. So even people not fulfilling major depression or depressive episode criteria will have sufficiently troublesome depressive symptoms. So I think we need to kind of be more open and consider any, let's say, clinically at least relevant depressive symptoms as something that potentially needs treatment. Whether the question means that if you have milder depressive symptoms, which are milder than you would not usually treat, and then the MCI comes as an additional target for treatment with antidepressants, I think that's more controversial, and I don't think the evidence is there yet.
So last question is post-COVID or long COVID and cognitive deficits. We're hearing a lot about this. I'd be interested in your view, Dag, but my understanding, and it's all preliminary, is that lots of the COVID and post-COVID enduring symptoms are actually in younger people rather than older people. But I'd be interested in your comment, Dag.
Well, it's a good question, and I have a manuscript here to review, which looked into this. So I cannot add much to what you say, and I think this is a very kind of important and interesting and probably very complicated area. There are probably a lot of factors playing in here in terms of cognition and but also on mood and anxiety symptoms. So clearly an important area to look into. And I know there are brain banks now collecting COVID brains, looking into them, and we look forward to hear these results in near future.
Yes, I think one comment I might make is that COVID seems to have caused or perhaps exposed lots of cognitive deficits in our politicians. but perhaps it's a topic for another day. I'll round up there and thank Professor Aarsland for his really very expert lecture. And this is an area that will grow and grow. I personally have a great interest in it as I grow older, and I look forward to more updates in the future. We have a 15-minute coffee break. We're 5 minutes over, but I think we should reconvene at 11:20. And I look forward to seeing you all then. Thank you very much.
Thank you. Bye-bye.
Thank you, Dag. Thank you.